The next topic is one that's near and dear to my heart, which is pharmacokinetics, or the uptake and distribution of inhaled anesthetics, which really is a topic that covers the factors that govern how anesthetics move into, within, and out of the body. It's a crucial factor in anesthesia. It's one that determines many aspects of anesthetic effects, inhaled anesthetic effects, including their workings, their toxicity, how they might affect muscles, how they might affect, indeed, all parts of the body. The focus of uptake and distribution usually is on the relationship between the alveolar and the inspired concentration. It's illustrated in this slide. The alveolar concentration is Fa, and the inspired concentration is Fi. This is the curve that you get for these four anesthetics when you deliver anesthesia using a non-rebreathing system. So this is a high-flow system, non-rebreathing system. And there are two messages in this slide that you need to appreciate. The first is that the anesthetics are different in their position. And the second is that the shapes of each curve are the same. The shape of each curve takes the following form. There's an initial very rapid rise to a knee that's labeled 1, and a secondary, slower but still fairly rapid rise taking place over the course of perhaps 8 minutes to a second knee that's more difficult to distinguish and labeled 2 here. And from this there's a third, still slower rise. And we need to understand the basis for these two messages, the difference in the position and the identity of the shapes. Now, we might explore this by talking about why the initial curve rise is so rapid. And in fact, this is related to the opposed or unopposed or partially opposed effective ventilation to drive the alveolar concentration upwards. And we can help ourselves a bit if we talk about a time constant. Well, let's do that. A time constant. The time constant is in fact a time. And it's a time that can be calculated if we know two things about any system. One is the capacity of the system, and the second is the flow through that system. The time that results is the time to a 63% change in the concentration of whatever it is we're delivering to that system. So for example, if we had the lungs have a capacity, and the lungs have a flow through them, the alveolar ventilation. What's the normal functional residual capacity of an adult patient? Give me an FRC, functional residual capacity. Give me.
About 2 liters.
About 2 liters. And what's a normal alveolar ventilation?
It's about 4 liters.
About 4 liters per minute, of course. So if you calculated for the lungs the time constant, it would equal 2 liters over 4 liters per minute. The liters cancel out, and the minutes go up here. And you'd see that the time constant for the lungs is a half minute. Half minute is the time it takes to produce a 63% change in some newly introduced gas, which means that if we're introducing some gas at time 0, there's nothing of the gas in the lungs. By the time we've gone one time constant, half a minute, we should be up to 63% of the way towards equilibrium. Very quick, very quick. In fact, we can think in terms of one time constant or 2 time constants, which would be 63% of what's left, that'd be up to 86%, or 3 time constants, which would be 95%, or 4 time constants, which would be 98%. In the case of the lungs, that'd be 2 minutes. Is there a gas for which the time constant applies that we use every day? What?
Oxygen.
Which is, say that again. What is that gas that we use every day?
Oxygen.
Oxygen. That's exactly right. So if you calculate or you measure, using a non-rebreathing system, the rate of change of oxygen concentration in the lungs, you get a curve like this, which is something we got in a couple of patients that we studied a few years ago. Within 30 seconds, we go up a change that's about 63%. A minute, we're up at about 86%. A minute and a half, we're getting close to 95, and so on. But the rise in FAFI for anesthetics isn't as rapid as for oxygen. Why is that? There must be some other factor that's coming into play. Anesthetic is brought into the lungs, and the rate at which it's being brought into the lungs, it should change the concentration of the lungs, is something we get from the time constant. But it doesn't quite work that way. We don't go up to 100% of what we're delivering. Why not? Something's opposing the effect of ventilation to drive the alveolar concentration upwards, and that something is?
Uptake.
Uptake. You got it all. Everybody, shout it together. Uptake! Right. So now we need to say, what is uptake due to? And it equals 3 factors. What are those 3 factors? Anybody?
Solubility.
Solubility. If you don't know the answer to a question, from here on out, it's going to be solubility half the time. Of course, half the time it won't be, but half the time it is. And we use lambda to designate solubility. What else, though?
Cardiac output.
Cardiac output. Good. And then one more factor, which is what?
Arteriovenous difference.
Arterial venous difference for the anesthetic partial pressure. So we'll make it alveolar venous partial pressure difference. It's the same thing as arterial if we've got no ventilation perfusion abnormalities and no barrier to diffusion of anesthetic. How do we define solubility? The first of those factors. Anybody, how would you define solubility? I said to you, tell me what the solubility of nitrous oxide is. What would you say if I said that to you?
Basically, you'd say it's a comparison of the concentration between 2 states where you have equal partial pressures.
That's exactly right. So if you've got nitrous oxide in the lungs and nitrous oxide in the blood, and the two are in equilibrium, then you might have this relationship. You might have 6% of some anesthetic. It could have been nitrous oxide, although you wouldn't be using 6%, would you? Not normally. But this might be desferrine, or it could be some other anesthetic. And at equilibrium, you find that there's 3% in the blood. That's a concentration ratio that's produced of 3/6, or 0.5. And what that says is that the anesthetic likes to be in the blood about half as much as it likes to be in the gas phase, if anesthetics had likings, if we can anthropomorphize. It says that the bigger this number is, the bigger will the uptake be. The smaller the number, the smaller the uptake will be. And here are such numbers. And indeed, for those of you that are taking your certifying exams or your board exams, these are numbers you've got to memorize. They are numbers to remember. They're probably the most important numbers that are associated with any anesthetic. They group themselves, interestingly enough, into 2 groups. One is a group of poorly soluble anesthetics, the desferrine, nitrous oxide, and sevoflurane. The other, a group of moderately soluble anesthetics, like isoflurane, enflurane, and halothane. Why do I say moderately soluble? Well, because there's some anesthetics no longer used which are highly soluble. Anesthetics like diethyl ether and methoxyflurane, which have blood gas partition coefficients of above 10. For ether, it was about 12, and for methoxyflurane, 15. So these are moderately soluble anesthetics. These are poorly soluble anesthetics. Note that the partition coefficient here is about 0.5, and here it's about 2. So memorize those values, if you will. The importance of solubility is not only in the blood, but also in the tissues, because that's going to be what's determining the difference between the alveolar and the venous partial pressure. After all, it's the tissues that stand between the arterial side of the circulation and the venous side of the circulation. They're what's causing this difference to occur. So we really need to think about the tissue solubilities as well. Before we get to that, though, let's go back to this graph and think about what were the 2 messages there. One was that the curves were different in position. Why are they different in position? We know the answer now, don't we? The answer is?
Solubility.
Hey, you're terrific. So which is the least soluble anesthetic?
Desferrine.
And the most soluble,
Halogen.
and the other ones are in between. The other ones are in between. And so the higher the solubility, the greater the uptake, and therefore the greater the opposition to the effective ventilation to drive the alveolar concentration upwards, and the lower this curve goes. And in a sense, the harder it is to develop anesthesia. The harder it is to develop anesthesia. And yet you say to me, look, I can give anesthesia and get a child anesthetized with halothane very quickly. How many of you have used halothane? Not many here. It's no longer used very much. But when we were using halothane, and we did use a lot of halothane, we would anesthetize children with, you could get a child asleep within a minute with halothane. Within a minute. And yet, that curve doesn't rise nearly as fast as does the curve with sevoflurane. But you can induce anesthesia, as I'm going to show you, almost as rapidly with halothane. How come? How can we do that? How can we?
Greater MAC multiples.
Exactly. So instead of giving just 2 MAC, as you might with sevoflurane, you gave 4 MAC or 5 MAC with halothane. The vaporizer would go up to 5%. You turn it all the way up. You use a high flow. And so you compensate for this effective solubility. And you get anesthesia in a minute or 2. Okay. As I said, we've got to also consider the tissue gas partition coefficients. Not only blood, which you saw in the previous slide, that's the blood gas partition coefficient, but also anesthetic solubility in lean tissues like the brain and fat. We need to note that desferrine and nitrous oxide are very similar in terms of their solubilities in blood and in lean tissues. They're the least soluble of these anesthetics. But that they differ significantly in their fat solubilities, with desferrine being 10 times as soluble as nitrous oxide in fat. And as we learned in the study of mechanisms of anesthesia, that probably explains why desferrine is much more potent than nitrous oxide. At least it explains part of it. Sevoflurane, on average, is about twice as soluble as desferrine. And isoflurane, on average, is about twice as soluble as sevoflurane. If we had halothane on this chart, we would note that it is about twice as soluble as isoflurane. Now, the solubility and the blood flow to tissues determine how quickly tissues will equilibrate with the anesthetic delivered to them. And this, too, is reflected in the FAFI ratio. So we have several tissues that we need to consider. In fact, the body tissues can be grouped into 4 tissue groups that are defined by their time constants. Some having short time constants, moderate time constants, and long time constants. The vessel-rich group is what its name implies. It's composed of those highly vascular tissues of the body. What would they be?
Brain.
Thank you. And what else? Is that the only highly vascular tissue?
Liver.
Liver,
Kidneys.
kidneys. So we got brain, liver, including, of course, the intestine, the kidneys, and what else?
Heart.
And the heart. Those are the primary highly perfused tissues, make up about 9% of the body mass, but receive 3/4 of the cardiac output. 3/4 of the cardiac output. So you got a very high blood flow, a high flow relative to their capacity. So their time constant is going to be short, 2 to 4 minutes. It means that they're going to equilibrate to 98% equilibration in what period of time?
A very short period.
A very short period. Can you be more specific? If I said their time constant is 2 to 4 minutes? How long to 98%?
Well, 4 time constant, so if it's 2 minutes, it'd be 8 minutes.
It'd be 8 minutes. That's right. So 75% of the blood is going to return to the lungs with the same concentration as it had when it left the lungs in about 8 minutes. The vessel-rich group will take up a lot of anesthetic initially. Why? Because it gets a big flow. Big flow. But this is going to narrow rapidly, and therefore its uptake will stop in 8 minutes. After that time, uptake is going to be by the muscle group, composed of muscle and skin, which shares with muscle the same solvent and perfusion characteristics, and therefore the same time constant. But this tissue group, much bigger, has a much smaller blood flow. and therefore its time constant is going to be what? Shorter or longer than with a vessel-rich group? Much longer, much longer. 30 to 60 to 90 times longer than with a vessel-rich group. The fat group is what its name implies. Why would we separate the fat group from the muscle group? Why not just lump them together? After all, they have about the same flow. If you look at the ratio of the flow to the volume, they aren't really that much different. So why would you separate them? Because of,
Solubility.
thank you, right. And which would have the greater solubility? The fat. And what would that do to the capacity of the fat to hold anesthetic? It'd be much larger. So the time constant for fat is much larger than the time constant for muscle. So after the muscle has come to equilibrium with the anesthetic, the fat is going to continue to take up anesthetic. And finally, we have the vessel-poor group. Bones, ligaments, tendons, cartilage, those tissues of the body which are poorly perfused. In fact, their perfusion is essentially zero. If their perfusion is essentially zero, how much uptake can they command? Zero, right. No flow, no uptake. So even though they make up nearly a quarter of the body mass, they don't contribute to the process. And the only tissue groups we need to consider are the fat group, the muscle group, and the vessel-rich group. And a consideration of this is what explains the shape of the curves. We can now understand the shape of the curves as an initial rapid rise, which is the unopposed or partially opposed effect of ventilation driving the alveolar concentration upwards. Fast time constant, the half-minute time constant. Why is it unopposed? Well, because at time zero, for example, there is no uptake. If there's no anesthetic in the lungs, what's the uptake? What's the uptake? Uptake equals this times an alveolar venous partial pressure difference, which must be zero if this is zero. So we have this rapid initial rise to a knee, that first knee, where there's a balance between the input by ventilation and the removal by uptake. And in fact, the balance is indicated by the position of that knee. So if the position were right here, if that were the first knee, we'd say that the uptake is determining about 40% of the anesthetic. That is, of the anesthetic being brought into the lungs, 40% is being removed by uptake. If it were down here, it would be 80%. That is, the rise would be to a point that's 20% of the inspired concentration. That's what you get with methoxyflurane. With these, it's about 33%. 33%. Now, uptake slows at that point, but it continues to rise to that second knee over the course of about 8 minutes. Which group is being saturated over that period of time? Vessel-rich group. And the end of that time indicates the end of the saturation of the vessel-rich group. We've got a slower rise after that, as uptake by which group gradually decreases? But it'd be the muscle group. Muscle group. So that explains the shapes of the curves and why the shapes are the same for all of these. They're the same because the factors that affect one are the factors that affect others as well. Now, if solubility were the only factor, then all things being equal, induction of anesthesia would be most rapid with which anesthetic? Desperate. And least rapid with? But we know that's not true, because there's another factor that we have to consider. Why is induction less rapid with desperate than with an anesthetic such as sevoflurane?
Because it's a pungent agent.
Pungent agent, that's right. And sevoflurane has a great advantage in its absence of pungency. This illustrates the pungency that exists at 2 Mac. So if you look at the percent of unmedicated patients who are breathing anesthetic, desperate, isoflurane, sevoflurane at 2 Mac, who complain of respiratory irritation, 75% given desperate complain, a little less than 50% of those given isoflurane, and none of them given sevoflurane. So sevoflurane's a pretty good anesthetic for induction of anesthesia. It's got a low solubility, and it's got absent pungency. In fact, we make use of that to induce anesthesia with one breath, or what we call one breath, which often turns out to be 3 or 4 or 5 breaths. And look at this.
Jennifer, what do you have planned?
What we're planning on doing today is a one breath inhalation induction. So what we're going to do is have the patient take a large breath in, we take a large breath out completely, and then we're going to have them take a vital capacity breath back in and
Sounds
go
like
out
a
and hold it and breathe normal after that, and he should fall asleep within about 60 seconds.
And sir, we've had to prepare you for that breathing exercise?
Yes.
Okay, great. Jennifer, what have you done back here?
Basically, we've run the circuit. We have high flow oxygen on, and we also have turned 8% sevoflurane on.
You've chosen sevoflurane?
Yes.
Why is that?
Basically, since it's a non-pungent anesthetic, we can increase to high MAC values and cause a fast inhalation induction, unlike some of the other anesthetics.
All right, looks like we're ready to start.
All right. You ready? Okay. Take a deep breath in. Now, breathe it out completely and hold it. And hold it then. The mouth kind of clear. Take a big, slow, deep breath in. Now hold it for a couple seconds. And now exhale. Just regular expirations. Breathe in normal.
Jennifer, it looks like he's beginning to get drowsy.
He's still breathing.
Yeah, so even the 8% sevoflurane enables him to continue breathing. His eyelids are getting heavy now.
Brian, can you open your eyes for me?
And he's losing his lid reflex.
Pretty good. Pretty good. Good anesthesia, and a terrific patient as well, wasn't he? And you can see that one breath produces anesthesia in about a minute of a high concentration of sevoflurane. Why isn't the patient asleep in 1 second? Why not? What's the obvious answer? There isn't enough time to get the anesthetic taken up into the brain, is it? It's got to move from the lungs to the brain. Okay, and there was this comment about, well, he's still breathing despite 8% sevoflurane. Why was he still breathing despite 8% sevoflurane? Jennifer, why was he still breathing?
Basically, your body self-regulates if you have spontaneous ventilation to the amount of anesthetic that will be taken up.
So what we've done is indicated that, in fact, 8% was not what he was getting in his lungs or in his brain, because 8% surely would have caused apnea to have occurred. So we have diluted the 8% with gases that remained in his lungs, and by the uptake of anesthetic, sevoflurane, including the uptake to tissue depots. We've chosen sevoflurane for this, and I think most of us would do that. We'll get into a little later why we would choose sevoflurane rather than halothane for induction. But I want to return to this issue of pungency of anesthetics. And we've said that pungency of anesthetics, like desferrine, will preclude us from using desferrine for induction of anesthesia. But that presumes that this pungency extends over the entire range of concentrations that might be used with desferrine. Let me show you this graph, though, which made one little change. One little change, and the change was, instead of 2 MAC, 1 MAC. At 1 MAC, the percent of patients complaining of respiratory irritation with desferrine, isoflurane, and sevoflurane is exactly the same. 0. 0. So maybe we could induce anesthesia with desferrine if we keep that in mind. And keep in mind the perception of pungency.
Opioid administration?
Opioid administration. So if we give a bit of pre-medication with fentanyl, maybe 1 mic per kilo, 50 to 75 mics of fentanyl, Well, of course, that depends on the weight of the patient, doesn't it? Yes. I was giving a talk on uptake in Omaha, and I said, now your average patient is 70 kilograms of hand shot up to. No, the average patient is 100 kilograms. Or morphine premedication, 1/10 of a milligram per kilogram. Notice the big difference in comparison with the saline premedication on the percent of patients who cough on induction of anesthesia with desferrin. 25% here with saline premedication, but 5% with fentanyl. So we can really lower the perception of irritation. And with a knowledge of these things, let me show you. In fact, you all showed that induction of anesthesia with desferrin is easily possible. Roll them, kids.
Señora, voy a darte el carete. Okay. Y puedes respirar despacio y profundo. Es el oxígeno.
You have a nice mask fit. So we're inducing anesthesia with nitrous oxide and desferrin. Nitrous oxide is at about 68%.
60%.
Inspired and 45% entitled. The desferrin is at about 3%.
Señora, baja la mano. Respira profundo y despacio.
So we have a little excitement.
I'm just going to reposition her head slightly.
Chin back a little more. Good. A little snoring now, so she's gone to sleep now. And with the exception of that brief moment of excitement, that wasn't too bad an induction.
Señora, puedes abrir los ojos.
I think if she's snoring, you're not going to communicate in any language at all. Okay, we have the inspired concentration is only 40% of that. So you're going to have to raise the delivered concentration in order to raise the alveolar concentration to what you want it to be. With isoflurane, a moderately soluble anesthetic, the rebreathing dramatically lowers the inspired concentration, and perforce then must dramatically lower the alveolar concentration, even lower. Relative to the delivered concentration, at 30 minutes, the alveolar concentration is 25 to 30% of the delivered concentration. What's that going to be when we substitute a less soluble anesthetic? What's going to happen to those curves?
They'll increase.
They'll increase. So let's see it with sevoflurane.
Well, we're going to demonstrate watching of sevoflurane at a low flow system. So we've turned our total gas flow down to 1 liter per minute of oxygen. And we're going to set the sevoflurane to a delivered concentration of approximately 2.8% and leave it there and watch our concentrations as they change.
Why don't you turn it on?
Okay. So we're going to turn to approximately 2.8% sevoflurane, just over a MAC, maybe around 1.2, 1.3 MAC.
Correct. We're at 30 minutes now, and taking a look at our time, 30 minutes, and our end-tidal concentration, we now have a 76% ratio, and it doesn't seem to have changed much.
No, I think we've reached the plateau portion of the curve at this point.
So it's just Same amount of rebreathing, but of gases now that have been exhausted of their anesthetic by a lesser amount because sevoflurane is less soluble. Less is taken up than is the case with isoflurane. But even that says that sevoflurane's inspired concentration is not the same as the delivered concentration, and the alveolar concentration will accordingly be affected. So the alveolar concentration, we would predict what, Jennifer? What are we going to predict?
It'll increase even further.
It'll increase even further. When we're giving 1 liter per minute of oxygen, we're about to turn on the desfrane. Why don't you do that and go to 8%? Very good. And now we're going to watch how quickly the desfrane concentration rises. Okay, Quinn, can you give us an update?
Well, we're now 30 minutes into our anesthetic with a delivered concentration of 8% desfrane and a flow rate of 1 liter a minute. And you can see their alveolar concentration of desfrane fell just short of my prediction of 6%. It's actually 5.6%, which is 70% of the delivered concentration.
Your vaporizer is a poor man's analyzer.
More so with a poorly soluble anesthetic.
Right, exactly so. So with desfrane, the inspired concentration relative to the delivered is again even higher than with sevoflurane, just as was predicted. The inspired concentration, in fact, now is above 80% of the delivered concentration, even at this low flow rate of 1 liter per minute, because uptake of desfrane is relatively small. And the alveolar concentration is about 70% of the delivered concentration. And as Quinn and I said at this point, this means that the delivered concentration, where you look at the dial setting, can be your poor man's anesthetic analyzer. You can say that the two are not all that far apart. You can control the anesthetic in the alveoli by what you deliver, even at this low flow rate. Now I want you to notice the separation of these curves. The separation is considerable. The desfrane curve is about 2.5 to 3 times the isoflurane curve. Big separation of those curves, which is vastly different from the separation that you see with a non-rebreathing system. That is, the lower the flow rate, the greater the exaggeration of the effect of uptake because of rebreathing. Why is this important? What implications does it have for control of anesthesia? Where do you get the better control of anesthesia?
At higher flow.
At higher flow rates, and with what kind of anesthetic? An anesthetic with a
Low solubility.
low solubility. Just write the answer half the time. What about for the cost of anesthesia? What implications does it have there? Which is going to be more costly if you have to consider raising the delivered concentration to get the alveolar concentration where you want it to be? With low flow, rebreathing becomes more important, and cost becomes more of an issue with the more soluble anesthetic. So the more soluble the anesthetic, the greater you have to raise the delivered concentration, and it's the delivered concentration that costs you. It isn't the inspired concentration or the alveolar concentration. It's what you have to deliver that costs you. Now let's talk about nitrous oxide. Nitrous oxide is different from the potent inhaled anesthetics in several ways. That very statement tells you what I want you to answer me now. How does nitrous oxide differ from the potent inhaled anesthetics?
First of all, it has a MAC that's above an atmosphere, so it's usually 105% of
Right.
atmosphere.
So we have to deliver it at high concentrations. And that has implications that are physical in terms of their uptake. We think of nitrous oxide as a poorly soluble anesthetic, and indeed it is relative to the potent inhaled agents, except for desfrane, and to a lesser extent sevoflurane. But the absolute quantity of anesthetic carried in the blood with desferrine versus nitrous oxide is vastly different, not because of any difference in solubility, but because of a difference in the partial pressure that's applied to the blood. The amount of nitrous oxide that's carried in the blood is rather substantial, and this has effects on gas-containing cavities within the body. It has other kinetic effects that we'll discuss in a moment. But if you carry a large volume of some gas in the blood to a cavity, it means that that gas now can expand what's in the cavity, particularly if what's in the cavity is a poorly soluble gas like nitrogen or sulfur hexafluoride, which cannot be carried away from that cavity. The solubility of nitrous oxide, again, is significantly greater than the solubility of these other gases like nitrogen, and that influences its diffusion through membranes, such as the membrane that might surround a cuff, that composes a cuff. And we have a little experiment that shows you the effect of.
So we developed an in vitro
Nitrous oxide
model of diffusion of nitrous oxide into the cuff of an endotracheal tube. What we have is the end of an endotracheal tube which has been sealed within this Veratrol. So I'm going to partially inflate the cuff with 5 cc's of air. And you can see the cuff is about half inflated there. We have our circuit hooked up to the other end. We're going to turn on some nitrous oxide in a very high concentration. And you'll see on the monitor the nitrous oxide concentration is going to gradually rise. It'll take it a few minutes. You can now see that we have an inflow and an outflow of 72% nitrous oxide and 28% oxygen. What we'll do is we'll check back in an hour, and the cuff of the endotracheal tube should be markedly distended from diffusion of nitrous oxide from the inside of the Veratrol to the inside of the cuff. So returning after an hour of 70% nitrous oxide, we see the cuff has become markedly more distended. The clinical correlation to this is that following a prolonged anesthetic with nitrous oxide, the cuff could become distended, as seen here, resulting potentially in tracheal mucosal ischemia.
That's a pretty good demonstration. And it does indicate the clinical significance that potentially correlates with this expansion of the endotracheal tube cuff. What are the other spaces within the body that could be expanded by nitrous oxide that are of concern to us?
In your ear.
Is that expanded, or is the pressure increased in the inner ear?
The pressure.
And what determines whether it's going to be a pressure increase or a volume increase?
If it's
The
compliant.
compliance of the space. So the inner ear is a fairly non-compliant, or relative to other cavities, it's fairly non-compliant. So that's a pressure increase. What are the spaces within the body that can expand in volume?
The lungs,
The lungs, meaning a pneumothorax. Okay, what else?
the abdomen, the intestinal.
The intestines, right, right. Anything else? An abnormal space within the body.
Pneumocephalus or something like
A pneumocephalus, but that would be the pressure again. Because like the inner ear, that's a poorly compliant space.
that. Air embolus.
An air embolus. Who said that? Say it again. What else?
Air embolus.
An air embolus. That's right. And that can expand dramatically because of the presence of nitrous oxide. Pressure can increase in the inner ear, or the middle ear rather. It can increase in pneumocephalus. And in one unnatural thing, where else can it increase?
Intraocular.
Intraocular, if we inject gas into the eye. And we'll see that in a bit. Nitrous oxide also has effects on gas spaces within the lungs during the uptake and the elimination of nitrous oxide. In the elimination, we have a phenomenon called diffusion hypoxia, where the outpouring of nitrous oxide, the large volumes that can be placed into the lungs, dilute the other gases in the lungs, including the oxygen. And during induction of anesthesia, we have two phenomena that results from the large volume uptake of nitrous oxide. What are those two phenomena? What are they?
The concentration effect
Right?
and also the second gas effect.
And also the second gas effect, which really is the same thing but applied to different gases. So here's an experiment which illustrates both the second gas effect and the concentration effect. This is an experiment in which either 65% nitrous oxide or 5% nitrous oxide was given to patients, and the FAFI ratio was measured. When 65% nitrous oxide was given, the rate of rise of the alveolar concentration towards the inspired concentration, the FAFI ratio, was more rapid than when 5% was given. Desfrane, at about 4%, was given in both of these cases. It was given with the 65% nitrous oxide and with 5% nitrous oxide. And when it was given with 65% nitrous oxide, the rise was more rapid than when it was given with 5% nitrous oxide. This illustrates the concentration effect, that is, the greater rate of rise of nitrous oxide with a higher concentration. And this illustrates the second gas effect, the more rapid rise of the desfrane when it was given with 65% nitrous oxide.
Dr. Reader,
Yes, please.
does the second gas effect work on elimination with nitrous oxide?
A little bit, but not nearly as much. Not nearly as much. So it really is a trivial effect on elimination. That is, can you eliminate things more rapidly because you're giving nitrous oxide? The answer is yes, but only a little bit. And we can go into why, but it's too long. Any other questions before we go on to the next chapter, which is genetic and immune? Yes, please.
Does the nauseating effects of nitrous oxide affect whether you administer it towards the end of an anesthetic at all?
That's going back to that earlier one. Which one are we thinking of here? Let's see. Does the nauseating effect determine whether you administer it towards the end of the anesthesia? We're going to get to that in another way, which is to say that we can minimize the nauseating effect of nitrous oxide by limiting the concentration to 50% or less. At 50% or less, in volunteers who are awake, the effect of nitrous oxide to produce nausea is minimal. At 60 to 70%, volunteers given that and nothing else vomit repeatedly. So it may not be a matter of whether you give it at the end or in the earlier part of anesthesia. What matters more, really, I think, is the concentration that you give.